she was the first to install the multidisciplinary approach in Vascular University many years ago. In addition, she had done much effort to promote the care of diabetic foot in Egypt and worldwide. And we were really inspired by her model, but we took a different pathway. We established a diabetic foot center that's multidisciplinary, but that's led by the vascular surgeon. So I'm going to share with you our experience. Our center was established in January 2011, so now we have about 11 years experience. All the patients are on a digital database, so the data is easily accessible and easily analyzed. And let's take a look how those patients presented. So 33% of the patients presented because they had non-ischemic diabetic foot ulcers. 24% of the patients presented with peripheral neuropathy. 20% of the patients presented with critical limb-threatening ischemia. Other presentations were less common, such as sarcoma, veins, especially venous leg ulcers in diabetics, intermittent claudication, acute ischemia, vasculitis ulcers, and others. Now, if you analyze these, you find that the majority of patients, 2/3 of patients, presented because they had an ulcer of some sort. Now, the question is, who is the physician that should be responsible of taking care of an ulcer? Is it the diabetologist or a physician with surgical background? Now, let's take a look how diabetic foot ulcers are managed. The principles of management are to identify deep ischemia, offloading, and infection. Now, let's take a look at ischemia. I think the key point in the ischemic leg is to identify the ischemic leg that needs revascularization. Some of those are very obvious, like this example, but mostly they are not so obvious. You get a patient with an ulcer, absent pedal pulses, and there is always a question mark: does this patient need revascularization or not? Now, the non-invasive tests that we all know, ABI, TOBI, they all have fallacies, and we know why. Because many of our patients have severe calcification extending even up to the digital arteries. And those tests often give false results, which could mislead the physician. Although we use the ABI and TBI and the option the ABI and TOBI we use them routinely and the option occasionally. We have devised our own parameter. I'm sure most of you are aware of it, ankle peak systolic velocity, which is the mean of the peak systolic velocity of distal anterior tibial and distal posterior tibial arteries. It's easy to measure during a routine duplex scan at no extra cost, very little extra time, and we have correlated this with the ABI and TOBI in non-calcified patients, and we published the results, and it correlates very well. And we've been using this now for nearly 20 years. We've found that the threshold below which a diabetic foot ulcer is unlikely to heal, and that is an ankle peak systolic velocity of 35 centimeters per second. So this answered the question: which patient with a diabetic foot ulcer and absent pedal pulses need revascularization? The patient with an ankle peak systolic velocity below 35, or an ulcer that's not healing or deteriorating, or an extensive foot ulcer that we revascularize even if the ischemia is not severe. Now the question is, who should make the decision? Is it a diabetologist or a vascular surgeon? Now let's take a look at our results of revascularization. I've selected a group of patients, a group of consecutive patients with the most difficult pathology, that is extensive tibial artery disease and difficult wounds that's classified as stage 3 and stage 4 according to I-5 classification. All those patients had tibial angioplasty. Now let's take a look at the results. Technical success, that is inline flow to the foot in the majority of patients. Complete wound healing in 74% of the patients in an average of 180 days. Amputation was performed in about 7% of the patients, mostly because of uncontrolled sepsis, and there was no 30-day mortality. Now, I think those results could not be achieved in this very difficult group of patients, except if the vascular surgeon not only would do the revascularization, but would take care of the patient, aiming at preventing amputation in every step until he reaches the endpoint. These are the amputation-free survival of this group of patients. Now let's take a look at a different pathology, non-ischemic diabetic foot ulcers. We're all familiar with these images of neuropathic ulcers. The principles of treating are offloading, surgical debridement, treatment of infection. Now, who should take care of surgical debridement? Is it a physician of surgical background or a dermatologist? Now, let's take a look how offloading is done. Surgical, walkers, total contact cast. Now, surgical offloading, we use surgical offloading in a select group of patients, tenotomy, tendon Achilles. We have seen many examples today, and of course, arch reconstruction in difficult cases by specialized orthopedic surgeons. Walker offloading in minor bone deformity, and total contact cast whenever there is severe bone deformity and that's not correctable by orthopedic surgeons. Many of those patients need the use of negative pressure wound therapy, and we have reviewed our results of negative pressure wound therapy. This is a retrospective review of 1 year of patients presenting with severe diabetic foot wounds that's classified as W2 or W3. There were 341 patients, which were divided in two groups. Group A were treated with negative pressure wound therapy. Group B were treated without negative pressure wound therapy. Now, there was a significant difference in the total number of wounds that reached complete healing in Group A as compared to Group B. There was also significant difference in major amputation, and there was also significant difference in mortality. Now, the question is, who should take care of those patients with severe wounds? Is the dermatologist or a surgeon? Also, there was significant difference in the mean time for complete healing. Now, I'd like to talk about a non-surgical presentation. 24% of the patients present with painful neuropathy. Now, those who come to the diabetic foot center have exhausted all the medical treatment for the control of painful neuropathy. We have introduced a relative new technology that is frequency rhythmic electrical modulation system, and I would like to share with you the results in a small group of patients. This graph represents the pain score on a visual scale as assessed by the patient at presentation and after treatment. The red color represents severe pain. So initially, the majority of patients presented with severe pain, and after treatment, the majority of patients had no pain or moderate pain. Finally, large limb effects. You have seen these images during Dr. Nihat's presentation. Very large wounds, which we covered by skin grafts. That's another example. And the question is, who should take care of these patients? So now I come to the last slide. The ones that are the pathologies that are highlighted in yellow are pathologies that need a surgeon, or preferably a vascular surgeon. Even the non-ischemic diabetic foot ulcers, because in those cases you need to make the very key decision whether to revascularize the patient or not. And this comes to the last slide: who should be the primary physician in a diabetic foot center? And I'm sure that all of you would like me to say the vascular surgeon, but I'll put conditions on this. That's a vascular surgeon who is very keen on doing everything possible to prevent major amputation for this patient, and who's also have the capability and the time to supervise the patient in every step until he reaches the complete the endpoint. This could also be a physician with the same interest, dermatologist with the same interest, and there is absolutely no doubt that there must be in the multidisciplinary team an orthopedic surgeon who have the same interest in working with these very difficult and complex pathologies. Thank you.